Thank you everybody for joining today's webinar, Reducing Risk in Twin Pregnancies. My name is Susan Hepworth and I will be facilitating today's webinar. I'm pleased to be joined by Dr. Andre Rabarber and Dr. Nathan Fox. Dr. Rabarber is a clinical OBGYN professor at Icahn School of Medicine at Mount Sinai. He's also co-director of the Division of Medicine at Inglewood Hospital and Medical Center. Dr. Fox, is a clinical OBGYN professor at Icahn School of Medicine at Mount Sinai, and he's also managing partner at Maternal Fetal Medicine Associates and Carnegie Imaging for Women.
Hi, everyone. Thank you so much for logging in to today's talk. Happy to be here. Thank you to Natera for sponsoring this, Hologic for sponsoring this, which I really appreciate. And yeah, so we're going to be talking about twin pregnancies. Can we reduce risk? I'm going to give a talk, then Andre is going to talk, and we'll take questions. I looked briefly through the participants, and it's nice. I know so many of you. Thank you for logging on. It's nice to see you virtually. Hope to see you in person. In terms of financial disclosures, Andre and I are being paid to do this, but Hologic was not involved in the content or the slide creation at all. So in terms of my objectives, I'm going to state that twin pregnancies are at an increased risk of complications. Okay, if you didn't know that, welcome to twins. Review evidence supporting some interventions that might reduce risk in twins. Obviously, we're going to leave a lot of time for questions and discussion and sometimes healthy debate. And I'm going to try to do this over Zoom without failure of Wi-Fi, internet, microphones, screens, mice, whatever it might be. So in terms of starting with twins, we refer to twins as high risk, and patients ask me all this time, am I high risk? Are twins high risk? Do we need to see a high risk specialist? And I try to focus the conversation away from this dichotomous high risk, low risk. And it's not just with twins, it's with all pregnant women. I don't believe that people can be divided into two groups. You're either high risk or low risk. It doesn't really work like that. And when I talk to patients about risk, I compare it to something like height, right? So there's always going to be someone who's taller than you and always someone who's shorter than you. And risk is the same way. And a lot of it is comparative. For example, I'm 5'11". So if I walk into an NBA locker room, I'm going to be very, very short. Whereas if I walk into, let's say, my daughter's classroom, I'm going to be very, very tall. And with risk, I try to impart upon people that everybody has risk for something. It's just a matter of risk for what is the magnitude, and ultimately, what can we do about it? And so the goal of this is to talk about with twins who are certainly at increased risk for several complications, what can we do to reduce that risk rather than just saying you're high risk, you need A, B, and C. So what are the risks that twins have? There's certainly an increased risk of preterm birth. That's a big one. Fetal growth restriction is the other big one. And then preeclampsia, which is important but less common. Stillbirth, which is obviously very important but fortunately less common. And then cesarean, which is common and debatable whether you want to call it important. It's certainly important to the patient in terms of her recovery and her experience. In terms of like pure medical outcome, it sort of depends how you define that. But it is a risk for sure to have a cesarean because of twins. So in terms of whether we can reduce risk, the way I wanted to set up this talk is I'm going to go through each of, I think, 11 or 12 potential interventions that we can recommend and to go over the data briefly, because I don't want this talk to be 15 hours, and then go through each of them. And I'm going to give my either thumbs up emoji indicating there's good evidence that it reduces risk, my thumbs down emoji, meaning there's really good evidence that it does not reduce risk, and then sort of the middle ground where we're not really sure and maybe more research needs to be done. So number one, don't have twins, right? One of the great ways to reduce the risk of twins is not to be pregnant with them. And I think this really falls a lot on us who might refer people for assisted reproduction, and obviously people who do assisted reproduction, to be very cautious with the use of ovulation induction agents, which, as you all know, can lead to twins, triplets, quadruplets, and so forth. And there has been a big push, which I think is a good thing, to go with single embryo transfer, if possible. For some people, that's not an option, but for most women, it is. I always counsel women, though, before IVF, that even with a single embryo transfer, there is about a 2 to 3% risk of monozygotic or identical twinning. In nature, that risk is about 1 in 300. and it's uniform pretty much across the board of identical twins. But when you do IVF, that process, probably something related to the manipulation in the lab, increases the risk. And so even if someone has a single embryo transfer, that'll lower the risk of twins significantly, but not to that of nature. It'll lower it to about 2 to 3%. I put multi-fetal pregnancy reduction in a smaller font and in parentheses because number one, Andre is going to talk about that. And number two, it's not considered like a primary preventative strategy, meaning I wouldn't say to someone, oh, do IVF, have as many embryos put in as you want, and if you have more than one, we'll just reduce. That's not a great strategy on the front end. It might be worthwhile on the back end, which Andre is going to talk about, but on the front end, not a great way to plan for having pregnancies. Second is low-dose aspirin. So low-dose aspirin is recommended by pretty much everybody for women at increased risk of preeclampsia. It includes twin pregnancies who are at increased risk of preeclampsia. The dosing in the US is 81 milligrams because that's what's available. It's debatable whether that is the ideal dose. Essentially here, you don't have many options for dosing other than potentially doubling up and giving 2 baby aspirin. We don't do that routinely. We give 1 baby aspirin daily routinely, and really select women, we might give 2. Best starting time is anytime before 16 weeks, generally, ideally by 10 to 12 weeks. It's a moderate risk reduction, meaning it lowers the risk of preeclampsia 10 to 20%. That's a relative reduction. So if someone's risk was, let's say, 10%, it'll lower it to maybe 8%, which is valuable. It's not huge, but there's really not much risk. In fact, there's really no risk of doing baby aspirin. So that gets my thumbs up. We recommend low-dose aspirin in all women with twin pregnancies, unless there's some contraindication. Next, cervical length and fetal fibronectin screening. So this is where people start to get into fistfights at national meetings, and it really just gets wild. People have religious opinions about this in both directions. The way I look at it is that in terms of the data, cervical length and fetal fibronectin, similar to singleton pregnancies, in twin pregnancies, both of them are associated with preterm birth. And you can predict preterm birth using cervical length and fetal fibronectin screening. So we did this in our own patients. This publication was in 2015. We took 611 women with twins. All of them got routine cervical lengths and FFNs. We created tables looking at prediction of preterm birth. What is their likelihood? You know, when will they deliver? What's the likelihood they'll deliver before 32 weeks, 35 weeks, and so forth. There's an article, you can pull the tables, or you can go to our website. mfmnyc.com is our website, /twin will get you to our twin calculator. This is available to doctors, midwives, nurses, patients. It's free, easy access. You'll get to a page that looks like this, where you can plug in the data. How far pregnant is this patient? What's her cervical length? What's her fetal fibronectin? And so, for example, in this particular woman, she's 26 weeks and 3 days with a cervical length of 11 millimeters and a positive fetal fibronectin. The predicted gestational age of delivery is 32 weeks, and the likelihood of spontaneous preterm birth, let's say before 28 weeks, is 37%, and so forth. And it'll do this for pretty much any value for the cervical length, fetal fibronectin, and gestational age. And this is one way to predict preterm birth in twins. Now, obviously, predicting preterm birth is not the same thing as risk reduction, because it does not necessarily prevent preterm birth. And this is where it sort of gets argumentative for some people. Some people believe that since you can't prevent preterm birth necessarily, you shouldn't predict preterm birth. And that's a reasonable argument to make. I don't personally hold by that. I think that there is value in assessing someone's risk, even if you can't necessarily prevent the preterm birth. That's a talk in of itself. But in terms of the data on this, we did look at this. We looked at the routine use of cervical length and fetal fibronectin, like we do in our practice, to see, are we actually reducing risk in anybody? And this was an interesting study we did with our friends over at Cornell, which is a retrospective study comparing 2 cohorts of twins. So the first group was 532 women with twins. This is our practice, who had routine cervical length and fetal fibronectin every couple of weeks. And the other cohort was 456 women with twins who only got those tests as clinically indicated. Now, what's interesting is our practice and Cornell are both on the Upper East Side of Manhattan, very similar demographics, a lot of IVF pregnancies, a lot of women in their mid to late 30s and 40s. And really the only difference is that at the time, At Cornell, they were doing these tests really just as clinically indicated, and we were doing them routinely. So even though it's not a randomized study, not a prospective study, we thought this would be a pretty good comparison of two similar populations whose only real difference in management or major difference in management was the routine use of cervical length and FFN. What we found was really interesting. The first is that, actually, as expected, using these tests routinely did not change the rates of preterm birth. So if you look in the group, our group that had it routinely, the average gestational age was 35.6 weeks, with 20% delivering under 34. And in the Cornell group, very, very same numbers, 35.8 weeks with 18% delivering under 34 weeks. These were not significantly different from one another. These are basically the exact same. So one of the takeaways, and this is how I counsel women, doing these tests will not keep you pregnant longer. That's not the goal. The interesting thing is we did look at steroid exposure, and we looked at women with twins who delivered under 34 weeks. And we found that in the group that had routine cervical length and fetal fibronectin, almost 92% of them did get steroids, the ones that delivered under 34 weeks, versus only 73% in the Cornell group. And this 73% is much more in line with the literature out there. If you look at studies examining what percentage of women who deliver under 34 weeks with twins get steroids, it's really in the 50 to 70% range. Cornell actually did pretty good compared to the literature, but it's not 90%, meaning the statistical anomaly here is the high rate of steroids in our group, not a low rate in their group. This is also true for women who delivered preterm but late preterm, 41% versus 14%. At the time, steroids weren't, this was before the study, the ALP study, so it was not recommended necessarily. But this is data. And then what was also interesting is we were not giving it to everybody, meaning the women who delivered over 37 weeks, only 8% ended up being exposed to steroids versus 4% in the other group, which is a little different, but not statistically. So this is really cool. We submitted it for publication, and one of the reviewers sent back a really astute comment saying, all right, you may be giving it to everybody, but maybe you're just giving it way too early, right? You get a short cervix, you give them steroids, and then they deliver 5 weeks later. Whereas maybe in Cornell, they might miss some, but the ones who get it, the timing is better within 2 weeks. And we said, oh, that's a really good point. Let's look at that. So we went back and looked at that data, and we found the opposite. For the women who were undergoing routine cervical length and fetal fibronectin, there was a higher rate of what we called optimal steroid exposure, meaning within 2 weeks of delivery and also within 1 week of delivery. So not only were more women getting steroids when they should, the timing of it was better with the routine cervical length and fetal fibronectin. So what we concluded from the study and what I tell patients is that doing these tests routinely does not seem to reduce your risk of preterm birth. That's sort of what we assumed would be the case. That's what we found in our data. But it might improve the rates and timing of antenatal corticosteroids for women who deliver preterm. Now, whether this translates into improved long-term outcomes for the babies, we don't know. And can you trust a retrospective study? We don't know. This would have to be sort of proven by a prospective randomized controlled trial with long-term follow-up of the twins, which would be great. That is not in the works. That has not been done, so we don't have that. But this is based on the data that we have, and this is how I counsel women, and this is why we do it in our practice. Next, bed rest. Short answer, not good. We don't recommend it. There's no known benefit to it. Hospitalization and bed rest has been studied, does not improve outcomes in twins. There's definitely a potential for increased risk, medical risk, certainly psychosocial risk, potentially economic risk, mental health. There's a lot of reasons not to put someone on bed rest. And for twins, there's really no reason to do it routinely, so we don't. It does not improve outcomes. Okay, cerclage. This is another area of debate. In discussing cerclage, it really has to be broken down into 3 separate categories. The first is history indicated, which for twins I'm defining as placing a cerclage because you have twins, not because of a history of multiple preterm births. The second is ultrasound indicated, meaning you have twins and your cervix is short on ultrasound. And the third, exam indicated, meaning you have twins and your cervix is open, dilated in the 2nd trimester. So you might be surprised to learn that the data is really very weak for all of these. For history indicated cerclage, meaning placing a cerclage because a woman has twins, it does not appear to be beneficial. But the interesting thing is, in terms of randomized women, in the Cochrane review, only 73 women have been randomized to cerclage or no cerclage because of twins. Doesn't seem to help, but that's pretty low. But all of the retrospective studies done on this seem to point in the same direction, that the women who got cerclages just because they had twins did not do better than the rest of them. So we don't recommend a cerclage for women for twins just because they have twins. Really, nobody, none of the organizations do. But the data is pretty weak, surprisingly, to prove that point. In terms of ultrasound indicated, so this is a really interesting story. There was a Cochrane review in 2014 with 98 women included, that's not a lot, that concluded that an ultrasound indicated cerclage in twins, meaning you have a woman with twins, you do an ultrasound, the cervix is short, that placing the cerclage is not only not effective, but in fact might even be harmful. Now, the authors of the Cochrane review did say that the data need to be interpreted cautiously because, again, it's only 98 women, and people who do meta-analyses know that's not a lot of women in a meta-analysis. But this statement was taken as like a law from God that you can't place a cerclage in twins with a short cervix, and it was deemed, you know, like a bad thing to do. Your doctor shouldn't do this. Your doctor doesn't know what, you know, he or she's doing if they try to recommend this. And so the pendulum sort of swung from doing a cerclage for women with a short cervix to not only not doing it, but sort of saying, if you do it, you're like a bad doctor. And I think that was a little bit too far, and the data did not support that type of conclusion. Coming back more recently, looking at this a little more closely, there are recent studies and meta-analyses showing some benefit potentially to women with twins in a short cervix, particularly if it's very short, like under 15 millimeters, which is one study by Amanda Roman. I was a co-author on that study, and there was a meta-analysis a couple of years ago showing the same. And so I think that it's really nuanced. I don't believe that all women with twins in a short cervix should have a cerclage, but I also don't believe that no women with a short cervix and twins should have a cerclage. It's somewhere in the middle, and there is some way to select who might be, who might benefit. Exactly how to do that is not known. Certainly, the shorter the cervix, the more likely it's going to help, or potentially other risk factors, or maybe the change over time. And we really do this case by case in terms of women with twins, whether we will or won't recommend a cerclage for twins with a short cervix. In terms of exam indicated, so twins with a dilated cervix, this used to be also very complicated because the data was poor. But there was a recent study also by Amanda Roman where they did actually a randomized controlled trial of women with twins and a dilated cervix in the second trimester, and they randomized them to cerclage or not. They actually stopped the trial early because the benefit was so great to a cerclage. In only 30 women, 17 with a cerclage and 13 without, the benefit was so great that it was already statistically significant and so robust that they said, you know, we can't even do the study anymore. We have to stop. The difference in gestational age of delivery was 6 to 7 weeks from diagnosis to delivery, right? Because you don't diagnose and place the cerclage on the same day, also in the order of like 5 to 6 weeks. The chance of delivering under 32 weeks, right? 100% of those who didn't get a cerclage delivered under 32 weeks versus 64%. But the big one is perinatal mortality. The women who did not get a cerclage, 20 out of 26 of the fetuses died or did not survive to come home, whereas only 17%. 70% is a high number, but it's certainly a lot lower than 76%. So based on this, if we have a woman with twins and a dilated cervix in the second trimester, we definitely recommend a cerclage. Part of the reason, I think, going back to ultrasound indicated, why it is probably beneficial in women with a very short cervix is many of them either do at the time of the diagnosis of a short cervix actually have a dilated cervix, or they will get one in a week or two. So I think that sort of points to the same idea. If someone's cervix is really short and it either is dilated or getting dilated, or going to be dilated, they'll probably benefit. In terms of progesterone, again, two ways to look at this. One is in all twins and one is in the setting of a short cervix. In all twins, it does not work. There's been a lot of studies that just giving progesterone to twins does not keep them pregnant longer. But for twins with a short cervix, there's actually pretty good data that just like in singletons, if you have twins with a short cervix, giving them vaginal progesterone seems to be helpful. And this meta-analysis was in 2017 by Roberto Romero. For pessary, same thing. You can look at putting a pessary in all twins versus in the setting of a short cervix. And the data are actually similar. There's been 2 randomized controlled trials of pessary in all twins, unselected twins, and there was no benefit. There's a lot of women, 2,000 women with twins. There was a randomized controlled trial of twins with a short cervix, which did show a reduction in spontaneous preterm birth. For whatever reason, pessary in twins is not taken off to the same degree as vaginal progesterone. ACOG's not really behind it so much. SMFM's not so much behind it. A lot of that is because there's meta-analyses that don't show benefit. There's problems with the meta-analyses. They include studies that weren't truly randomized. It's a little bit complex. Also, it's unclear, that the pessary is helpful on top of vaginal progesterone or just vaginal progesterone. And so there's still some uncertainty about pessaries. They're harder to place. You have to learn how to place. So they haven't been picked up as like a big recommendation by big societies. In our experience, we use them sparingly. Some women with twins get them. Those are the very short cervix. Maybe they're too late for a cerclage. Vaginal progesterone isn't working. It's not harmful. At worst, it's annoying. And so annoying to place, annoying to have. Most women who have it don't feel it. They're not in any pain. It doesn't bother them, but it could. But I don't think it's a risky thing to do. And so we have incorporated this into our practice, again, for select women with twins with a short cervix. It's just something to know about. Moving on to nutrition and weight gain. This is a big area of research for me in our practice. There are recommendations for weight gain in twins, and it's a lot, right? The recommendation for women of normal weight is 37 to 54 pounds in pregnancy. That's more than a pound a week. That's a lot. And this is not based on great data, but this is what the Institute of Medicine did recommend. These are just, giving you some idea of how much research we've done on this. This has really been an area of interest of mine. There's more studies in this that we publish, but this is something we look at a lot. And if you put it all together, basically, women with twins who don't gain enough weight have worse outcomes. Now, whether if you made them gain more weight, it would improve the outcomes, right? There's an association versus cause, but the association is very strong. Women who gain less weight have worse outcomes, smaller birth weights, more fetal growth restriction in terms of percentiles. Interestingly, more preterm birth than spontaneous preterm birth, which is not something you might expect, but it's been across the board. This was a study we did in 2014, just to illustrate this. And this is one table from it. And we looked at women's weight gain early in pregnancy. So women with twins, we looked at their weight gain from prior to pregnancy to 16 weeks. So the first 16 weeks of pregnancy. And we plotted out their weight gain into quartiles. So the bar on the left is women who gained less than 2 pounds, less than or equal to 2 pounds in the first 16 weeks. The next bar is women who gain 2.1 to 5.5 pounds, 5.6 to 10, and then greater than 10 pounds. And look at their likelihood of spontaneous preterm birth under 32 weeks. And it was a straight shot. The ones who gained the least amount of weight, 15% delivered before 32 weeks versus 9, 4, 2, which is really, really impressive when you see this kind of data. Again, it's retrospective. We can't say 1,000% sure that if I gave these women, more encouragement to gain weight, that it would have helped. We don't know that, but it is intuitive that it would help. And then there was a really interesting study out from Barbara Luke, who's done a ton of research on weight gain in twins. And she did a prospective cohort study where she had twins who did and did not enter her specialized prenatal program, which include a lot of visits focusing on dietary education, high calorie diets with supplements, and very high weight gain goals. Again, it was not randomized. Patients could self-select to enter this clinic or not. So all these results need to be taken with a grain of salt, but her results were pretty impressive. The women in her program, 190 of them, compared to the women not in the program, had, again, they had better rates of preterm birth under 32 weeks, lower rates of preeclampsia, and improved neonatal outcomes in terms of birth weight, NICU, and morbidity. So would I say that improved nutrition and weight gain might be a simple and effective way to reduce the risk of preterm birth and twin pregnancies? There's certainly other benefits to proper weight gain and no known risks in twin pregnancies. So I put this in the thumbs up category, even though the data are not perfect. They all point in the same direction. A few final things in terms of exercise and routine pregnancies. We do encourage women to exercise. It's not clear what this is, whether it's beneficial or not in twins, but I do recommend it in twins. The only people who I have cut back potentially are those with a shorter dilated cervix or other issues. But I don't, that's its own talk, obviously, what to do with someone with short cervix, to tell them to back off their activities or not. But in terms of the sort of standard twin pregnancies, I tell them they should continue to exercise until I tell them not to. And mostly I don't tell them not to. So I made this as sort of an uncertain, but I do recommend exercise in twin pregnancies. In terms of routine ultrasound, there's a lot of reasons to do it in twins. You have to determine the chorionicity and amionicity early. You need to know about placenta location, vasa previa, obviously the anatomy. Andre's going to talk a lot about monochorionic twins. And then again, fetal growth, position, fluid, biophysical profile. So this is a thumbs up. Routine ultrasound in twins is a good thing. In terms of antenatal testing, and I'm talking about NSTs or biophysical profiles to reduce the incidence of stillbirth, there are no randomized data on twins, but there's no randomized data on any of this. So for NSTs and biophysicals, whether you're talking about diabetes or hypertension or advanced maternal age, there aren't good randomized studies. It's really just observational studies. And in twins, it's the same. So we looked at biophysical profiles, which is what we do for our twins. And we looked at the IUFD rate. It's very, very low. And the positive screen rate, meaning the number of people that had an abnormal test that needed further testing or potentially delivery, was also low. So this is what we do in our practice. We do biophysical starting at 32 weeks. And that's the biophysical, just the ultrasound component, meaning 8 points, leaving out the non-stress test, which is available, but we don't do it routinely in twins unless there's a problem with the biophysical. And then finally, in terms of vaginal delivery, so in the setting of a cephalic presenting first twin, right? So baby A's head first, and a provider, doctor, midwife who knows what they're doing, vaginal delivery of twins is known to be safe. And this is true even if you induce labor. And then even though overall outcomes are similar in terms of morbidity, mortality for the moms and the babies, there's clearly a reduction in the outcome of cesarean delivery. It's so interesting in these studies when they compare, let's say, maternal morbidity, and they say it's equal, whether you do a C-section or an induction. It's really unfair because they don't include cesarean as a morbidity, even though it's like a laparotomy. It's a major abdominal surgery, which, I would say is a morbid thing to have. It's not, it's not going to be lethal typically, but it's certainly, undesirable if not necessary. And so even the studies that show similar morbidity between cesarean and, let's say, induction or, spontaneous labor for twins, keep in mind they're not including cesarean in that calculation. And clearly, if you labor twins, the ones who deliver vaginally will not have a cesarean. So just to review, things that I believe do reduce the risk in twins. Number one, try not to have twins. If possible, low-dose aspirin, the exam-indicated cerclage, doing vaginal progesterone or pessary for a short cervix, good nutrition, ultrasound, antenatal testing, and vaginal delivery. Things that might be beneficial, routine cervical length and fetal fibronectin. Again, whether it overall improves outcomes is not certain. It does predict the risk of preterm birth and maybe improve steroid exposure. Ultrasound indicated cerclage. Again, I believe there are some women for whom they'll be in the thumbs up category and some women for whom they're in the thumbs down. So I put it overall in the middle category, and exercise is the same. Things that don't work, bed rest, placing a cerclage automatically, doing progesterone automatically, and doing pessary automatically. So these are my twins. They were born in 1999. This picture was taken the summer of 2000, and this picture was taken in the summer of 2020, 20 years later. So they did all right. And if you want to hear more from me, from our practice, we have a couple of podcasts you're welcome to subscribe to. It's free. I don't get paid for any of this stuff. One is called Healthful Woman, where we go over topics in women's health. This is available to you, to your patients, to your friends, to your family. God bless. We go over a ton of topics of OB and also gynecology. And then High Risk Birth Stories, which is where women, including those who deliver twins, get to tell their own birth stories, which has been pretty cool. So I thank you for your attention, and I'm going to hand it over, I believe, to Andre.
So the second half of the talk was going to be how to avoid having twins. Now that we've learned that all ills of pregnancy are twins, except actually postdates and macrosomia. Those are the only two things that twins are not at higher risk for in pregnancy, and having a singleton increases your risk for. Everything else, including preterm birth, preeclampsia, diabetes, all are increased in having twins. And obviously the type of twins you have affects that risk assessment. So reducing risk by fetal reduction is really the talk we're going to sort of discuss, which is a bit controversial, but I think certainly relevant and part of the conversation that should be brought up with patients as an option if they're certainly weren't planning to have twins. Most patients who go into becoming pregnant are actually through fertility treatment are planning to have one at a time and are not planning to have twins. And so it's always a bit of a shock that they do that. And particularly with the single embryo transfers where they have twins that are sometimes monochorionic, which lends even more risk. By the way, as an aside, I am a twin, but I have no ill will towards my brother. We get along just fine. But he would have been if we would have gone through this logic, he was twin B. So if any case, he would have been reduced. Going to the talk in 2004, Dr. Evans actually wrote this controversial piece presenting his case for consideration for doing a reduction in twins to singleton. Is this reasonable? And based on a small series of patients, he had about 50 patients. A large proportion of them were also advanced maternal age. And then he compared it to national data on twin outcomes. He suggested that the loss rate actually of doing fetal reduction is lower, the loss rate of the whole pregnancy by reducing to a singleton than continuing an ongoing pregnancy for twins. That doesn't even include, beyond the pregnancy loss rate prior to 24 weeks, it doesn't even include the decreased morbidity and prematurity from a fetal consideration. And so he advocated that this certainly should be part of our discussion with a lot of patients. And prior to that, really, it was only a consideration for quadruplets or higher at that time, and maybe triplets. People would sort of waffle and suggest maybe that was reasonable. But at that time, we were delivering quite a lot of higher order multiples, which have thankfully decreased. So looking at multi-fetal pregnancy reduction, the concept is that it's actually termination of one or more fetuses. For MFPR, requirement really is to have separate chorionicity. So dichorionic or trichorionic or separate in quads, placentation is important. And that's been shown in doing fetal reduction that it clearly increases gestational age. You increase birth weight. For per fetus that you reduce, on average, you gain an extra 3 weeks in length of gestation. You gain approximately 500 to 600 grams in birth weight. There's significant reduction in the rate of preterm birth as well as early preterm birth, particularly for higher order gestations. And some maternal complications such as preeclampsia and cesarean section may be diminished by doing a reduction. What often isn't talked about is that the economic and psychological impact of multiple gestations and twins, if you look at the data, over 25% of parents with multiples experience depression and anxiety disorder in the perinatal period. So this is a particularly high-risk group for postpartum depression and surveillance and monitoring, of which we probably do a pretty poor job of that, since we just call them back at 6 weeks, and that's about it. The technique itself, in this case, is in the imaging shows a triplet gestation with a monochorionic pair, so a dichorionic triamniotic triplet pregnancy. There's mapping out of the fetuses. There's still placentation location. And then generally somewhere between 10 to about 14 weeks, fetal reduction is performed, and you can select out based on ultrasound features as far as the nuchal, the neck thickness, or a lagging crown rump length, or obvious abnormalities. About 40% of lethal abnormalities can be identified with first trimester ultrasound, transvaginally and transabdominally. So we do kind of an extensive evaluation of the fetus. Or you can additionally add CVS to ensure normality of the remaining fetus. We often do that for our 2-to-1 fetal reductions. Data on that suggests no increase in loss rate, appreciably above the baseline. And that was by Dr. Stone and her colleagues. The procedure is commonly done by injection of potassium chloride into the fetal thorax using a 20 or 22 gauge needle. Some people will use digoxin or lidocaine, and the procedure generally takes a couple of minutes, is quite quick. Now, selective termination is the procedure that you identify a fetus in a multiple gestation, usually after 16 weeks, that is known to have a chromosomal structural genetic abnormality, and that's usually after 16 weeks. And data suggests that that's associated with a higher incidence of potentially loss rate from a 2-to-1 reduction in under 14 weeks. We generally quote somewhere in the order of 1 to 2%. Loss rate prior to 24 weeks or less, but by 16 weeks, it may be as high as 5 to 6%. But again, depending on the series, most of the data is observational, retrospectively collected. There's been little obvious randomization in this type of study to be able to get great statistics. So looking at fetal reduction for twins, again, there is no prospective randomized controlled trials that have been performed. Traditionally, it's been done in the setting of maternal medical diseases. So if the mother has severe cardiac disease or underlying kidney disease, or particularly a high incidence of preterm delivery, cervical incompetence, Mullerian, uterine anomalies, all of these have been suggested as indications not to carry twins and to suggest reduction. Fetal conditions, particularly those that might be severe, lethal, and might be associated with an increased risk for preterm birth. Very advanced maternal age data on the women 45 and above with twins suggest that there are higher incidence for earlier delivery, potentially higher incidence for growth restriction, as well as preeclampsia in this population, particularly most of them using donor egg. And so data suggests that this population uniquely may benefit from this greater than the younger cohort in twins. And then obviously elective decisions. And ultimately, applying this to monochorionicity, we can talk about, but at this point, multifetal pregnancy reductions in the traditional sense is only applied if you have dichorionic gestations. And for monochorionic gestations, that generally you cannot do the traditional needle procedure intracardiac. So what does the data show? This was a paper we had worked on from our group that was published in 2015, looking at a single retrospective, single center outcome. We looked at about 63 pregnancies, of which, and then compared it to our ongoing dichorionic diamniotic twin gestations, managed in a similar practice, similar fashion. In this setting, the reductions were performed between 11 to 24 weeks. 50% of them were selective terminations done after 16 weeks, usually for a medical indication of a structural problem. And then of those that were done in the 11 to 14 week range for traditional MFPR, the majority of them were also 50% were done for a genetic or structural problem, but some, about half of those, so I'd say about 20 of those cases, they were purely elective. Those patients chose not to carry twins. And what the data showed is that there was, at least in our practice, a lower rate of preterm delivery, less than 37 weeks. That was statistically significant, but no difference in the risk of preterm birth before 34 or 28 weeks. And lower risk for birth weight less than the 10th percentile, but no difference for infants less than the 5th percentile. And there was no difference in the risk of fetal demise after 24 weeks. So interestingly enough, we suggested while there was an impact on birth weight and preterm birth, it was often late, not early. Most recently, in 2019, Dr. Stone and Dr. Vieira, our colleagues from Sinai, also published a large single center series from their experience, much larger numbers of 2-to-1 reductions done. They had about 250 pregnancies, and they compared those reductions to non-reduced twin gestations. And they showed that, again, a higher mean gestational age at delivery, 39 versus 36.7 weeks, consistent with the data of per fetus, you gain an extra 3 weeks. There was a reduction in preterm birth less than 37 weeks that was statistically significant, as well in their cohort, a reduction in preterm birth less than 34 weeks. That was statistically significant. There was not a statistically significant reduction effect on birth weight, though there was a trend towards improvement in birth weight. Cesarean section rate was decreased by doing a reduction. Preeclampsia was also statistically significantly reduced. Preterm premature rupture of membranes was less, though the numbers were small, though a trend towards that, and a non-statistically significant reduction in gestational diabetes. There was no significant increase in unintended pregnancy loss rate less than 24 weeks between the two groups. So overall, reassuring that significant decrease in short-term maternal and fetal morbidity based on this data. And finally, most recently, there was a meta-analysis on fetal reduction of 2:1 that was published. Now, this was a large group of studies that were done, and the reductions occurred as early as 6 weeks, as far as 15 weeks. Most of those reductions are done in Europe. They're done transvaginally, and they're mainly embryo aspirations under 10 weeks, 6 to 8 weeks, but was included in this meta-analysis of early reduction combining with the traditional reduction done in the United States after 10 weeks. And what they showed is a 30% lower preterm birth rate based on 5 studies that was statistically significant, as well as higher birth weight in these 4 studies by about close to 550 grams. There was no differences in the miscarriages between the reduced and expectantly managed participants. So again, reassuring that you're prolonging gestation, improving birth weight by doing reduction in this setting. Finally, what the unique considerations of monochorionic twins are that they share a placenta, and their vascular system is intertwined. Again, that varies. They have artery to artery, artery to vein, and vein to vein anastomoses within the placenta. The variation in these anastomoses, too few or too many, depending on which studies you read on this, suggest that some unique disorders can occur, such as twin-to-twin transfusion syndrome. Generally, I counsel patients that occurs at about a 15% rate, where there's shunting of blood across and one gets too much blood flow. In that setting, that infant actually creates polyhydramnios, has higher cardiac output, more renal output, and then the one that is not getting enough blood flow becomes growth restricted, low fluid. Is sort of the caveat of IUGR associated with Ollie-Poly syndrome. You have Doppler abnormalities and other cardiac compromise, and there's staging systems. Most traditionally, people use the Quintero staging system. And interventions that have been described in these settings include laser treatment, which seems to have about an 85% success rate of having at least one live birth, but only about a 60%, 65% chance for having both survive it once you're getting into more severe TTTS that requires laser treatment. Then you get into a TRAP sequence, which is twin reverse arterial perfusion that often happens in an acardiac co-twin, where you have reverse perfusion and the one pump is pumping for both. Twin anemia polycythemia syndrome is a unique subset of TTTS, occurs 1% of the time, and that often is associated with anemia in one fetus and polycythemia in the other. That polycythemia can result in vascular events, arterial events like strokes in one fetus and anemia in the other. Treatment with laser is controversial, and that's why currently for all of our monochorionic twins, we do MCA Dopplers looking at the middle cerebral artery peak systolic velocity flow to assess if anemia is developing in one of the fetuses. Finally, selective growth restriction, which can mimic TTTS, but the difference is that you do not see polyhydramnios in the other fetus or cardiac compromise. And selective growth restriction, one fetus is just growing poorly. That can happen quite early in the 2nd trimester, as much as in the 3rd trimester. Incidence ranges in the studies from 15 to as high as 30% in monochorionic gestation. So these are unique considerations when you're dealing with one placenta. And despite all of that, even if all of that does not develop, the monochorionic twins have a higher incidence of long-term neurologic sequelae, including an increased risk for cerebral palsy that's independent of gestational age at delivery and prematurity for some odd reason. And so these are significantly high-risk pregnancies. And a lot of that has to do with this shared circulation. And that's why we can't do a fetal reduction, because doing a KCL reduction in one would result in co-twin demise in the remaining one. So cord occlusion was developed. Cord occlusion, stopping the blood flow instantaneously and separating the vascular system of the fetus, is one mechanism of performing a reduction in the setting. Bipolar, cautery, laser, photocoagulation, radiofrequency ablation, as well as suture ligation have all been described. The most common one that people are using are radiofrequency ablation at this time. And traditionally, it has been offered for those that have either failed laser treatment or do not wish laser treatment in the setting of severe TTTS, severe early onset growth restriction, or discordancy for fetal anomalies. And so the Rossi paper that was published in 2009 looked at umbilical cord occlusion of varying techniques for selective feticide and monochorionic diamniotic twins. And generally, they associated, at least in their series, survival was greater if this was performed after 18 weeks versus earlier. And survival by RFA, which is the most common technique that people are using, radiofrequency ablation, was 86%. The majority of co-twin deaths occurred within 2 weeks of the procedure. If it did occur, an overall neonatal death rate was only 4%. So carrying on with this study, the only interesting thing was, again, that there was a 7% neonatal morbidity rate related to neurologic injury. But again, the problem with this paper was these were not elective cord occlusion feticides. These were all patients where it was indicated based on the severity of either growth restriction, anomaly, or IUGR. And so it is unclear what the exact etiology was, whether it's the actual RFA or the underlying condition that was associated with this neurologic injury. The RFA technique, just to kind of go over what that is, the probe itself is about a 17 gauge needle. We use local anesthetic under ultrasound guidance. A Levine needle is inserted into the fetal abdomen directly above the cord insertion site. The prongs are deployed, as you can see in the upper right-hand corner. The extent with which the prongs are open is the extent of the level of thermal ball or energy that you are diffusing. It's about 30 seconds of that. We don't fully deploy the prongs. We just sort of halfway deploy them because we just want to focus our photocoagulation to the level of the cord insertion site. And within 30 seconds, usually we do two separate sessions of flow stoppage, and that's basically it. And cessation of flow is pretty instantaneous with this technique and relatively quite simple for a lot of us who are used to doing cordocentesis. Routinely, this is actually technically easier. Prospectively, in 2014, there was an observational study of 100 consecutive cases of RFA, and they associated, again, a live birth rate of 78%. Median gestational age at delivery was 35.15 weeks, which isn't really that different than most monochorionic diamniotic twins. However, the issue, if you look at their grouping, was that a lot of those patients were also more complicated. Some of them were monochorionic monoamniotic, some were dichorionic triamniotic triplets that they reduced, and some were monochorionic triamniotic. And so you had a lot of different groupings. It wasn't purely just monochorionic diamniotic triplets, and the indications were not elective. These were in the setting where there was fetal growth restriction, anomalies, trap sequence, or TTTS in this population. So they a priori were a higher risk cohort of problems, not electively being done. But again, the delivery was low, under 32 weeks in a high-risk cohort, and post-procedure abnormal MRI was actually at 3% versus 7% from the Rossi analysis. And most recently, Rao and colleagues and we participated, Dr. Fox and I, in the study, but the main lead investigator is Dr. Joanne Stone. And it's a very interesting, compelling study where they looked at a single center retrospective analysis of elective RFA. And we pooled chorionic diamniotic twins that were managed together between both of our groups, and compared to about 14 patients who electively chose to have RFA. And the mean gestational age at RFA was earlier at 15 weeks in this cohort. And this was really one of the first papers that I know of to look at this electively in patients where there is no ongoing problem with the pregnancy, that it's treated. And there was a higher rate of term deliveries in the elective RFA group, 38 versus 35.9 weeks. So that was statistically significant. And also there was patients with ongoing pregnancy had significantly increased risk for preterm birth, less than 37 weeks, but no difference at 34, 32, and 28 weeks. There were no pregnancy losses or terminations in the RFA group. Of 22 patients, or 7.3% with ongoing monodi twins had pregnancy losses less than 24 weeks. And then on the ongoing monodi twin gestations, 12% required, which is consistent with the data on TTTS and TAPS and so on, 12% required some kind of medical intervention, whether it was RFA, laser treatment, or amnio reduction, for one of those conditions developing. So if you combine that data, ongoing monodi pregnancies, you've got close to about 19%, or 1 out of 5, where they either develop a requirement for a procedure itself or had a pregnancy loss less than 24 weeks. Whereas those with the RFA, there were none that had losses under that. And so again, quite compelling data to suggest that this may be something to offer these high-risk pregnancies before trouble starts at early gestation in those patients that electively choose not to incur the risks of these pregnancies. How do we manage pregnancies after fetal reduction? We do anatomical scans at 16 and 20 weeks. We've actually been doing earlier scans these days under 14 at 12 to 14 weeks with the nuchal, basic anatomical studies. We do cervical lengths on these patients, even in 2-to-1s. We will do at least one standard cervical length at 20 to 22 weeks. And interestingly enough, we wrote a paper years back looking at multifetal pregnancy reductions and the impact on cervical length, as well as fetal fibronectin. This was in 2001 and 2004. And there was no impact on false positive fetal fibronectins or cervical length being altered by fetal reduction itself. And so it's something that can be considered in those patients if the cervix is shortening or symptoms of threatened preterm labor occur. We don't routinely do FFN in this population in a symptomatic setting, but only if they are symptomatic. We continue to do growth scans on these patients every 4 weeks and have not and manage them as a higher risk cohort. So essentially, from a counseling perspective, fetal reduction may actually be the most effective means to decrease the loss rate of the whole pregnancy prior to 24 weeks in a twin gestation, as well as decreasing preterm birth in twins prior to 37 weeks. The problem is that there is no long-term neonatal and infant data, and given the advances of neonatal care, that may not matter that much for the long-term effect on twins. They may stay in the NICU about 2-3 weeks, maybe more, but long-term outcome may suggest that it may not be that different. And I think that's just the limitations that we have of the data right now. We know that short-term benefit is clearly there from a maternal and fetal outcomes measures, but what really the money's on the long-term data, and does it really have an impact? And that is still a hard question to answer for a lot of patients. Finally, according to the American College of OBGYN, when a patient requires information regarding fetal reduction, non-directive counseling should be offered and all necessary information should be provided. And I think this is just like a quick, nice primer to suggest that we can talk about short-term benefit. It is still, the jury's still out whether there is actually true long-term benefit to reduction or not in these high-risk pregnancies at this time. Thank you for listening.
The first question is, when it comes to mono twins at our hospital, we routinely admit them at around 25 to 26 weeks for monitoring until delivery. Would this type of twins be the exception to the rule when it comes to routine hospitalization for twin pregnancies?
Yes, a good question. I was not referring to monoamniotic twins, and the reason they're admitted early is not to prevent preterm birth or anything like that. That's more because they need fetal monitoring, because the thought is they're at increased risk for sudden stillbirth. So in our practice, we also admit our monochorionic, monoamniotic twins somewhere between 24 and 28 weeks, depending on the exact situation. Again, but for totally different reason. That's for fetal monitoring, not because of the risk of preterm birth. So yeah, that's a good point to make. I was referring to more uncomplicated twins.
Okay. Which pessary is used in the selected twins with short cervix?
Yeah, so the data is mostly on what's called the Arabin pessary, after Dr. Arabin, who's a wonderful doctor. And it's essentially, it's like a donut or a ring-shaped pessary, and there's a way to insert it where one side goes towards the uterus and the other side outwards, and it goes around the cervix. If you look at some of our, trying to think, there are definitely images of it online, and certainly in some of the talks we've given. But if anyone needs more information, you can certainly reach me through our website or through email or through the talk, and I can get you more specifics. But there you can order them, or ones that are just like it's in the US.
Okay. And this actually is a question specifically for you, Dr. Fox. It seems useful to use TVCL and FFN testing in asymptomatic twin pregnancies to provide antenatal corticosteroids appropriately. How do you manage symptomatic twin pregnancies in their evaluation of preterm labor if they present to the hospital? Do you utilize TVCL and FFM in that setting as well?
Sorry, I'm back.
Hey, Andre, welcome back. All right, I'll just answer that one question. We've been doing some Q&A, Andre, while you were, speaking to the netherworld. So in terms of women with actual sort of symptoms of preterm labor, ideally you would use fetal fibronectin and cervical length as part of your triaging. It's not always as doable practically. First of all, if there's been any bleeding or cervical exams or cervical lengths or intercourse, you can't do the fetal fibronectin. You can't do it reliably. So that's number one. Number two, on our labor floor, we don't have a vaginal probe in order to do a cervical length. Some places they do, which is great. Ours, they don't. So potentially we'll see them in the office and maybe do some of the work up there, like at the cervical length, maybe fetal fibronectin if you can. But ultimately, it's a clinical decision based on their contractions, based on their risk factors, based on their cervical exam, based on all of these variables that come in. But ideally, a cervical length and a fetal fibronectin could be a part of that. But it's just it's important, because we teach our residents and our fellows and talk to patients about this. You have to look at the entire patient, and to say someone, oh, her fetal fibronectin is negative, nothing's going to happen, she's perfectly fine. And mostly that's going to work, but certainly you have to look at the entire picture and decide how you're going to manage that patient. And so when women have symptoms, it's a totally different system. The data I was going by is all asymptomatic women. Everything I presented from our patient population, we actually excluded women who presented to triage with symptoms because it's a different subset. That's a really good question.
How often do you check for cervical dilation in twins in second trimester to determine need for cerclage?
We usually will do every 2 weeks cervical length from 16 to 24 weeks. And if it's short, below 1.5 or 1, we will check for dilation. But over 1.5, we generally don't do pelvic examinations.
Yeah, just to add to what Andre's saying, again, our routine is to do cervical length every 2 weeks. And one of the interesting things is a lot of people don't realize that you do a cervical length and it's particularly short, like under 10 millimeters or 1 centimeter. If you put a speculum in and take a look, very frequently they're 1 centimeter dilated. And that's part of the reason why women with a very short cervix might benefit from a cerclage, because they may already be dilated. So we do that. And then we'll either have them come back in 1 or 2 weeks based on the exact circumstances. And pretty much every time the cervix is that short, we're going to keep doing speculum exams to look. I personally prefer a speculum exam to a digital exam. Some people do both, but that's how frequently we do it. We wouldn't do it routinely. The cervical length is normal. We wouldn't do speculums or pelvic exams.
Okay. What are the odds that someone will have twins if they don't run in the family, or if they don't do IVF or any sort of fertility treatments? Are there even any odds?
Hi, Kate. Great question. Nice to hear from you. Um, in for identical twins or monozygotic twins, for women not having IVF, the rate, interestingly, is the same across all humans at all places, at all ages. So the chance of having an identical twins is just a statistical likelihood, like rolling the dice. You know, you're 1 out of 36 times you'll get snake eyes. It's the same thing with twins, and it's about 1 in 250 to 1 in 300. Again, the only exception is having IVF increases that. For non-identical twins, or what we call dizygotic twinning, like Andre and his brother Ted, that risk is related to things like family history. So that's when twins run in families. It could be that maternal age increases the risk. There are certain populations and geographic locations that have increased risk. So that one can be dependent on other factors, but identical twinning does not. It's the same.
And the only thing to add was maternal age. As
Yeah.
interestingly enough, maternal age is a risk factor for twinning. So
Yeah.
while fertility rates theoretically diminish, miscarriage rates increase as women get older, twinning rate actually increases as women get older. The higher risk is in the 40 and above cohort, interestingly enough. And then with IVF, the only thing I would add is with embryo manipulation, it's thought with PGS or others, it's thought that that may increase the rate of monozygotic twinning, and that ends up being at about 1%. So 1% of IVF, you get monozygotic twinning.
Okay, we have a couple of questions here that kind of go together. So, Dr. Barber, you mentioned risk of postpartum depressive disorders in parents of twins. What is the incidence of depressive disorders in women who have reduced a twin or greater order multiple pregnancy?
So interestingly enough, the long-term, there are some psychological long-term studies looked at patients after they delivered. And these early works that were done in the 90s suggested that 95% of patients were comfortable with the decision they had made as far as fetal reduction, and did not have regret or remorse about the decision. And 5% still did think about it and had some regret or remorse. That doesn't mean they felt it was the wrong decision, but clearly they were potentially affected by that. So that's generally how we counsel patients, but I think it is an important thing that should be addressed, and it is part of the counseling that I do when I talk about reduction with patients. And we do offer patients seek therapists and counselors during that procedure or after the procedure, because it is important to talk this out with the couple why they're doing it. Often the best resolution for couples are when both are on the same page. Rarely we've had scenarios where the one person does not want to do the reduction, the other does, and there's sort of a lot of discussion and fighting between as to what would be the best choice, and that lends itself to a lot of need for counseling and marriage counseling and things of that sort, for sure.
Okay. In what situations would you suggest two baby ASA?
Yes, since I mentioned that, I'll take that. It's hard to say specifically because this is really a newer concept for us. There's some data, when they look at the baby aspirin and the reduction in preeclampsia, there's some sort of sub-analyses indicating that 150 milligrams, which again is not available in the US, so here would be 162, is better than 81 milligrams and lowering the risk of preterm birth. But you would assume there's probably a slightly higher risk of side effects, potentially, or complications, and it's not really known. So we've only done it for a handful of women. I mean, people with like recurrent preeclampsia, severe early onset, despite being on baby aspirin, for example, in one pregnancy. So it's hard to give a general rule of exactly who it is. It's not really mapped out, but definitely, women who are very high risk, and particularly those who maybe got early onset preeclampsia despite being on 81 milligrams, maybe we'll try 162 in the next pregnancy. But it's really, I mean, we give a lot of baby aspirin out, and the 162 has been only a handful in the past 6 months, not very common.
Okay. Any early admission for mono-di twins for monitoring?
I'm sorry, say that again.
They ask any early admission for mono-di twins for monitoring?
We don't admit them to the hospital for monitoring. We do the monitoring as an outpatient. We do deliver monodi twins a little bit earlier, which is, we basically follow the most recent ACOG recommendations. So typically our monodi twins, there is a range. We try to keep them pregnant till 37 plus weeks. Obviously, if there's things like fetal growth restriction or any concern of, TAPS or TTTS, we'll do it earlier. But for uncomplicated monodi twins, we'll usually see them weekly at the end until about 37 weeks, and then either induce or do a section if they haven't gone into labor. And then with complications, it depends on the situation. But we don't admit them just for monitoring.
Okay, and we've got a few more questions here. Does a twin pregnancy increase risk of uterine atony and or rupture?
Uterine atony for sure, like postpartum hemorrhage, definitely. Uterine rupture, I'm not sure. I understand. You would imagine it would be, but again, if someone has a history of a cesarean and now they have twins, the data are pretty reassuring actually for women who try to be back with twins. The rate of rupture in one of the largest studies was about 1%, which is sort of the same as in singleton pregnancies, maybe slightly higher if that risk is 0.7%, but it's pretty similar. For a non-scarred uterus, I mean, it's so rare in general. I would guess it's probably a little bit higher in twins, but it's still going to be exceedingly rare if there's no scar in the uterus. Andre, would you agree with that?
Yeah, I think the only thing I would say is that I do tell them that it might be double the risk, because I generally quote feedback rates of 0.5 and versus 1%. And, probably because that lower segment, if you get to term, might be a little more attenuated, but it's so hard to tell. And the numbers weren't large. And so it's really hard to know if that is real different. But a spontaneous uterine rupture alone without a prior scar, that I wouldn't say that that's increased in this population. Or if it is, it's it's well under 1% anyway. So.
Okay. Please discuss management of SIUGR with mono-di pregnancies.
That's you, Andre.
Yeah, so I think that gets complicated because there's actually selective IUGR actually is broken up in 3 different types: type 1, type 2, type 3, depending on Doppler abnormalities. And so it really depends on Doppler abnormalities, but often our management has to do with increased surveillance and monitoring, depending on, simplistically, if Dopplers are normal, umbilical artery Dopplers, by that I mean, we generally don't do, though others have suggested MCA as well as UA Dopplers might be beneficial. We do MCA Dopplers for the follow-up of for TAPS, but not for IUGR often. And for that population, if it's normal, we'll do weekly antenatal testing and growth scans every 2 weeks. For those with abnormal Dopplers, we tend to do twice weekly. If the Dopplers are abnormal to the point where you have absent or reverse, often we start discussion, depending on gestational age, of admission to the hospital and timing of delivery. But a lot of this is gestational age dependent, as well as the severity of the IUGR. But that's a simplistic overview of that.
Okay. How much do you believe increased levels of glucocorticoids impacts the onset of preterm birth?
That goes back to an old study looking at CRH levels in twins being higher than in singletons. So, and the theory behind that, though, again, it's not clear what the signal is for preterm birth, whether it's CRH levels, whether it has to do with myometrial stretch receptors that affect preterm birth, or whether it has to do with placentation abnormalities that may lead to the cascade for preterm birth, like IUGR and CRH signaling from the fetal side. So I don't think we know what the etiology for preterm birth is in this population. And I would also suggest it may not be CRH alone. It may just also be shorter cervix, ascending infection, preterm premature rupture of membranes. This population is at higher risk for that as well. And so I think it's multifactorial as to what the etiology for preterm birth in twins is. It isn't purely one cause, which is why we have so much problems treating it, actually, because there's going to be no magic bullet to stop preterm birth when you're talking about a syndrome which has multiple pathways leading into the sort of common final event of inflammation, and IL-6, IL-8, collagenases. You start to break down cervix and inflammation, and then ultimately the labor cascade. And so the problem is that there are many pathways still that lead to preterm birth in twins, and it isn't one singular pathway.
Okay, and I think we got time for about 2 more questions. So can you talk about the risk of vaginal birth of twin A and turning a breech twin B versus C-section?
Can you repeat that question, just so I understand what?
Sure. Yeah. And it's not a complete sentence here, the way the question came in, but it just says risk of vaginal birth of twin A and turning a breech twin B versus C-section.
Okay, no, I think I understand. I mean, in general, so in our practice and the way we do it is very similar to how it was set up in the twin breech study, which came principally out of Canada, but it was international, as well as how the French have published it. And essentially, if twin A is head first, there are some exceptions, but basically, if twin A is head first, we're comfortable laboring her. And so baby A is breech, we're not going to do it. So after twin A delivers vaginally, twin B can either come down head first, in which case, you can break water, she can deliver vaginally, she can just push and deliver. Twin B can come down as a breech, in which case you can sort of grab the baby's feet and do a breech extraction. Or, twin B, you may want to manipulate the position. And traditionally, there was a lot of thought in the US about taking twin B that was breech and turning it abdominally, doing an external cephalic version to get twin B to head first to let the baby come out that way. And it was argued that that was a good strategy because, providers aren't really comfortable with breech extraction. Maybe it's safer to do it this way. And so there are studies on this, and it is successful some % of the time. And so it's an option. But in our practice, we don't do that. If the baby is breech, we're going to do a breech extraction. And in fact, if the baby is head first, this baby B is vertex, but not engaged, I mean, it's very high up or it's oblique or you're really getting the shoulder, we'll actually go and do the opposite, flip it from head first to feet first, called an internal podalic version, to do a breech extraction of twin B. And the reason being, the main morbidity for twin B is the longer time after delivery of twin A. Because again, you can monitor the heart rate and show that the baby has good oxygen, and that's true, but you may end up with a very long second stage for twin B. You could end up with an abruption. You could have a cord prolapse, the heart rate can drop. And if you're trying to push, unless the baby's very low, your only option is to do a cesarean for twin B. But if you're going to do a breech extraction of twin B, the baby's going to be out a minute or two after twin A, no matter what. And so we've had good success with this, as has the French have published this, with a very, very low rate of a cesarean of twin B. The vaginal twin A, cesarean of twin B, which you can call a combined delivery. I call it the vaginal delivery, which I don't think is a great outcome. In our series and in the French, it's under 1%. It's very, very rare. Whereas typically in most countries and most studies, it's between 4 and 10% where twin B is going to end up with the cesarean. So we don't try to flip twin B to head first. If we're going to do any flipping, we're going to flip it to feet first so we can deliver the baby quicker. And so that's how I would answer that question. But for someone who's uncomfortable delivering a twin as a breech, and you have twins in labor, it is an option to try to do that, but you really have to counsel the woman that she has a 5 to 10% chance of a cesarean for twin B, and she may not want that risk. She might say, you know what, if that's the case, just do a cesarean for both, or can you please find me a doctor or midwife who can do a breech extraction? And I think that these are important conversations to have, ideally before the onset of labor. Who's going to deliver my twins? And is the patient comfortable? Is the doctor or midwife comfortable? And to sort of sort that all out on the front end rather than when she's fully dilated. That's a bad time to have that conversation.
Okay. And we have one last question that came in and then we will wrap up. Is there any benefit to using nitroglycerin after vaginal delivery of twin A if twin B is breech?
We don't do it routinely. We don't give uterine relaxants routinely. It would be potentially an option if we thought the uterus was contracted and not releasing, and that's preventing a vaginal delivery. The way we do for twin B is if she was on Pitocin, we just stop it after twin A. And if she was not on Pitocin, we wouldn't start it. And we just make sure she has a very hardy epidural, because that could be quite painful to reach in and do a breech extraction of twin B. Nitro is an option for someone with, very tetanic uterine contraction, but we don't do it routinely.
Usually the uterus is quiescent after the first one delivers for a couple of minutes, and really you should take that window of time to get the baby out as quickly as possible. The data shows that the time interval from A and B delivering, the longer that is, the greater the risk for cesarean section and fetal distress for the second one. So ideally you take that window and you go in before the uterus contracts and the cervix contracts. If it has already, yes, we use nitroglycerin, we've used terbutaline, we've used uterine relaxant, but then you run the risk of postpartum hemorrhage afterwards, though nitroglycerin goes out pretty quickly.
Great. Well, Dr. Barber and Dr. Fox, thank you so much for joining us today for the very informative presentations, and thank you for being able to answer so many questions. Everybody who has been on today's webinar will receive a follow-up email from Hologic with more information. So Dr. Barber and Dr. Fox, thank you so much for joining us.
Thanks for having us. Thanks for setting this up. It was great.
Bye-bye. Have a great afternoon, everyone.